This is Jill Henry, DNP student at Rocky Mountain University of Health Professions. I will review the Johns Hopkins Nursing Evidence-Based Practice Model. In 2002, the organizational leadership at the Johns Hopkins Hospital recognized a gap in the standard for nursing practice of implementing research results. The Johns Hopkins Nursing Evidence-Based Practice Model guides bedside nurses in translating best evidence into practice for clinical learning and operational practice. Here are the goals of the Johns Hopkins model. The tenets of evidence-based practice support the goals of the model because A, nursing is both a science and a profession. B, the best available evidence is the foundation for nursing practice. C, a hierarchy of evidence exists. And D, research findings should be translated into practice. And finally, E, nursing values efficiency and effectiveness. A key objective was to select a model that would demystify the evidence-based process for bedside nurses and embed evidence-based practice into nursing practice. I love that bedside nurses were involved in evaluating and piloting the model and process to be used at Johns Hopkins Hospital. The resulting model includes a conceptual model, a process, and tools to guide nurses through the critical steps of the process using the PET process. This model has been incorporated into undergraduate and graduate research courses at Johns Hopkins University School of Nursing. This model begins with inquiry sparked by an individual's or team's genuine curiosity about best practices related to a specific problem and/or a particular patient population. This inquiry initiates the PET process, which is practice, question, evidence, and translation. This provides a systemic approach for nurses to develop and refine a practice question, to seek out the best evidence, and then to translate that best evidence into practice. Working through the PET process promotes learning as individuals and teams gain new knowledge and insights that impacts practice. Insights gained through practice changes can also lead to additional learning opportunities, making this a continuous and a dynamic process. Through the PET process, best practices to answer practice questions are identified, leading to improvements in the areas of clinical, learning, or operational practices. The PET process is the core of the Johns Hopkins model. It consists of 3 phases: practice question, evidence, and translation. Within these phases, there are 19 prescriptive steps. Although the process appears linear, it may be iterative as the process evolves. For example, teams may discover other sources of the evidence through their review or hand searching, which requires a refinement of the search strategy or PICO process, moving them back to prior steps. So the first stage is the practice stage. This is where a question is refined in answerable terms, a leader is designated, and an interprofessional team is formed. And this consists of 5 steps. Next is the evidence phase. The end of this phase consists of 3 distinct activities that require evidence synthesis. Recommendations are developed by the team based on the level, quality, and quantity of evidence. And then the selection of one of 4 pathways to translation is based on the overall strength of the evidence. So the first pathway would be strong, compelling evidence and consistent results, which is a prerequisite for a practice change. A second pathway would be good and consistent evidence, which is an indication for considering a pilot of the practice change or a need for further investigation. A third pathway would be good but conflicting evidence that requires further investigation for new evidence or a research study. And the fourth pathway would be little or no evidence, or it requires further investigation for new evidence or a research study, or simply a discontinuation of the project. And finally is the translation stage. This is where a plan is constructed for implementation of appropriate and feasible recommendations. And this ends with implementation, evaluation, and dissemination. These 10 tools were developed with input from bedside nurses and include key questions that prompt nurses in the process. The tools were constructed to have high utility with checkbox formats, definitions, and guidelines for use on each form. A critique of the Johns Hopkins Nursing Evidence-Based Practice Model is the pros are it does demystify or break down the evidence-based process, making it easy to understand and use. Initiation of the process occurs organically as an individual or a team recognizes a problem within their organization, on their floor, or in their team, and then works towards evaluating the evidence and going through that PET process and that checklist and using those tools. The cons would be that it is not strong, does not have a strong focus on team decision making. So that would be maybe you could consider the Iowa model or a different model if that is the goal. Of course, any evidence-based practice model, it needs to be clear to the clinician, it needs to fit the organization and help guide the organization using a systemic approach to an evidence review, ultimately leading to a practice change. Here are my references. Thank you.